Good morning, everybody. I'm Christina Oldini. I am the Associate Director of the Mid-Coastal Perinatal Outreach Program. This morning, we have a special guest, and that is Dr. Diana Ramos. And we are so thrilled that Dr. Ramos has joined us from Sacramento. And Diana, first of all, I want to thank you for your years of service to women and families in California, and additionally nationally. And I want to point out that unfortunately, we are having a glitch this morning. Dr. Ramos is so gracious. Unfortunately, at this moment, she won't be on camera. And Diana, I want to welcome you and thank you.
All right. Good morning, everyone. And thank you so much for the opportunity to be here with you. I was just sharing with Christina, wow, had I known, I would have not had to put my makeup and my suit on, but that's okay. I love the opportunity to dress up. I am so thrilled to be able to be here with all of you and share the amazing and exciting work that is happening in California. When I was asked to do a presentation, I thought, you know what? I want to share all of the innovative work that is happening in California because we are truly leading the way for the nation. We've proved it over the past decade and plus of work that is happening in California in terms of the toolkits, the maternal mortality reviews, so much that has been accomplished, and that has all been able to have been done because of all of us working together. So I am thrilled to be able to share some of the new and innovative work that we are now moving forward. Can I have the next slide? No disclosures. Next slide, please. And so what we are going to be doing is that we're going to review some perinatal data just to set the groundwork. Where are we starting? Where do we need to go? Where are the opportunities for improvement? And then we'll look at some cross-collaborative initiatives, and then finally opportunities for everyone to help our office and all of our partners to move the needle and to really take us over the top and have the best outcomes, not only in California, but in the country. Next slide, please. I'm not sure if this video worked because when we were in prep, it was not working, but nope, it's not working. Okay, so we can't get the volume, and I apologize sincerely. This is the tech issues. We gotta love it. Can you please stop the video? And basically what this video is, if you are not familiar, I would encourage you to go to the CDC website that focuses on the Hear Her campaign. This person is an athlete, an Olympian athlete that unfortunately had what we have heard over and over again, a near miss event in terms of maternal mortality, maternal morbidity. And it just highlights the fact that no matter who we are, despite our education, despite our status and as an Olympian, you know, unfortunately, disparities do exist, and sometimes we have no control over trying to eliminate those disparities. But I think the first and most important thing to do is to recognize the fact that all of us have some susceptibility to negative outcomes, but more importantly, by understanding the data, we can then understand the opportunities for improvement. So let's look at some of that data. Can I have the next slide, please? Oh, one back, please. Okay, perfect. So this is California data from 2012 to 2022. And again, we know that maternal mortality disproportionately impacts women of color. And we can see here the need and really the call for improvement that needs to happen in the Black population. You can see the data. But you can also see that unfortunately, maternal mortality has increased. If we look at the numbers, from 2015 to 2017 to 2018 and 2020, maternal mortality has increased in the Hispanic, Asian, and white population. It has improved in the Black population, so we're moving in the right direction. It's 3 to 4 times higher in the Black population, but we cannot overlook the fact that unfortunately the other races and ethnicities are increasing as well. So we have work to do. We cannot overlook that data. And so this is telling us that what we are doing has to be applied and implemented to everyone. Next slide. And as you can see, the national data compared with the California data, this is really the 2018-2019 data. This is the work that we have all done as a state. If we look at from the beginning when data was initially collected at 2012, there were some changes in the way that the data was collected in, I want to say 2014, and so that's where it looked like it went up and then it went down. But bottom line, look, we are less, and our rate is better than the US data. But this is not good enough, because one mom is one mom too many to be lost to maternal mortality. So we need to really make sure that we have the lowest, if not zero, maternal mortality rate, not only in California, but in the nation. And you can see here in 2019 to 2020, because of COVID, there was an increase in the bump of maternal mortality in all, not only in California, but also in the nation as well. Can I have the next slide? So innovative ideas, that's the title of this presentation. So when I became Surgeon General as an OBGYN, one of the things that I really realized that we needed to do is to come up with innovative ideas that are really going to accelerate and positively impact our outcomes. You saw our data. We had the lowest maternal mortality rate in the country, but what can we do differently? And I used my business background to really pull in a diverse set of minds. And last year, about in April, we came together, and you can see the snapshot of the folks here. And we pulled in not only the usual partners that we have for maternal health, as well as government. We pulled in business leaders, technology innovators, people who are in the AI space, and really wanted to come up with what are some things that are innovative, that are different, that can push us to an improved outcomes for not only maternal mortality, but morbidity. And so these were the recommendations that the group came up with. We need to focus in 2 areas. One are the consumers. And I say consumers because these are the general public. These are people who are not necessarily pregnant yet. And we need to build trust. We need to take into consideration that there has been historical trauma, and all of this is adding to the fact that people are not trusting the healthcare system. And people need to be active participants in their health. These were the things that we were recommended to focus on. Now, on the healthcare system, we've been doing amazing work with all of our toolkits, looking at the data, but we need to identify risk early on and act on that. Right now, the other big opportunity that is happening is technology and AI. We need to meet people where they are, how they are communicating, how they're accessing information. And we are hearing so much on this on many levels. And unfortunately, it's not happening fast enough in healthcare. But the reason is that we are dealing with lives. And so we have to be extra careful in how information is shared, how information is gathered. So all of that is being taken into consideration. And finally, we need to improve the diverse representation of our community health partners and build on those partnerships and continue to advocate for improved care. So let's go on into a little deeper dive into these 2 areas. So as California Surgeon General, I am committing to California that we are going to be establishing a strong start and beyond. I know that many people have heard of strong start, and strong start oftentimes just implies pregnancy, but really we are going beyond. We are going beyond pregnancy, and we are moving into the interconception, preconception care. This is the work that we have been doing across the state ever since I started in public health in Los Angeles County. So it really is an honor to be able to come full circle and help lead the state in moving us in that strong start and beyond. Next page, next slide, please. We have to remember that 80% of health happens outside of healthcare setting. This is one of my key messages as Surgeon General that I keep on saying over and over again. It is not that 5-minute quick prenatal check or the 20-minute, if you're lucky, postpartum check that happens, that is going to make a difference in a person's health. It is everything else outside of that healthcare setting. It is health behaviors, the physical environment, the social and economic environment that really make a difference in the healthcare. And that's where we have to pull in our community partners. We have to pull in the technology that is already being used with our, by the entire population, not only in California, but throughout. Next slide, please. So trust, I mentioned it, so critically important. Without trust, we cannot move the needle. People need to know that we care for them, that we are listening. And this is something that I found that I thought, you know what? It's not only in building a relationship with somebody, with your partner. It really is. This is what we need to do in healthcare. We need to be open. We need to understand. That means listening and just say when things are not right, when things are wrong, and our actions need to match our words. And oftentimes when we're busy doing our charting, we're on the computer and not really listening to our patients. It's hard to multitask. We're hearing that over and over, and we need to be honest with each other. We need to respect each other, not take each other for granted, and let go when something goes wrong, and really value each other's opinions and respond with empathy. Simple, right? So we need to reinforce this not only in our relationships with each other, but more importantly, with our relationships with the healthcare system. And it's not easy. And so that's why one of the things that we are focusing on is really using those trusted ambassadors in healthcare, such as doulas, community health workers, promotoras, to help us be that bridge to communication, to help us be able to reestablish those positive relationships. So we're in California. Can I have the next slide, please? And it wouldn't be California if we didn't take advantage of the resources that we have here. And that is Hollywood Health and Society. I'm very proud to say that I'm an alumni of the USC Annenberg School of Medicine, Annenberg School of Communication. And so the Annenberg School of Communication at USC has this Hollywood Health and Society. And if I put the QR code there, I would invite you to check out what they have. What they do is that they obtain information from various experts in the field, whether it is systemic racism, they have a portion on maternal mortality, and they make the information available to the screenwriters. And any content that they want to put in their scripts, whether it is a series, a movie, it really does promote from Hollywood, from the entertainment aspect about health. And the easiest analogy that I can bring of, and the most recent, is Ted Lasso. Ted Lasso did an amazing job with mental health. So why can't we do this with maternal mortality, morbidity, building up trust? So we've actually had a conversation with Hollywood Health and Society, and they are willing to partner with us and really try to integrate some of the key messages that we think are going to make a difference in reestablishing trust. Next slide. And we can't do it, as I mentioned earlier, can I have the next slide, please, without our doulas. And thank you so much to Shantae Davies. Shantae has been amazing in partnering with us. She said, once trust has been earned, health information is better shared and received, and active engagement and decision-making can occur. Shantae has been gracious enough to share with us the 15 questions about pregnancy and postpartum developed in Fresno for the Black population. So we are in the process of partnering with Shantae in creating videos so that people can listen to the most common questions and the responses. These responses are based from ACOG recommendations, as well as the Society for Maternal Fetal Medicine, and really getting accurate information. We're going to be sharing it with OB perinatal providers as well, so that they know what questions patients may potentially be asking. But again, elevating the trust. And the people who are going to be in the videos are going to be people that look like the people that they are serving. So people of color, being able to increase the partnership, the workforce of people that look like the patients they are serving, whether they're doulas, midwives, nurse practitioners, physicians, so critically important in reestablishing that trust. Next slide. So moving on, active participants. We talked about how patients really want to be active participants in their healthcare. So again, we're thinking innovatively and out of the box. I was listening to an NIH maternal mortality seminar that happened last year. And one of the things that they talked about was the fact that we need a tool. We need something that provides patients with the ability to know what their risk for pregnancy complications is going to be before they become pregnant. We don't have that right now. So our team is working steadfast with Dr. Cesar Padilla from Stanford and Dr. Susan Perez from UC Davis to develop a patient-initiated medical risk assessment. So this is outside of the healthcare setting. So for those of you who are physicians, nurse, midwives, this is nothing to do with you. This is outside the healthcare setting. And what it is, it's going to be a validated healthcare, it's based on a validated healthcare setting questionnaire. It's going to be done before pregnancy. It can be done anywhere by anyone. So if you are the partner, if you are the grandmother, the future grandmother, and you know the risk of the medical history, you can complete it. It is objective because bias is eliminated. It is based on medical history. There's no information on race or ethnicity. We know that race is a social construct, and it plans to educate on actionable items based on risk, and the results, if the person wants to, can be shared with the healthcare provider. So completely innovative. Next slide, please. And this is what things that would happen. So once a person knows their risk, they'll be educated about what their potential risk is, connect them to resources, and more importantly, empower people to make informed health decisions. And this is one of the pieces that is oftentimes missing. As an OB/GYN, I can tell you that many times people came into the office and for their first prenatal visit, and just looking at their history, I can know immediately, wow, you had 2 previous C-sections, you had severe preeclampsia, and I would tell them you're going to be high risk. That was not what they wanted to hear. They wanted to be able to share the fact that they maybe wanted to have a new birth plan, that they wanted to have sometimes a home delivery. But so, we already start with a disconnect in terms of that first prenatal visit. This is an opportunity for folks to have a little bit more information on what their personal history is outside of the healthcare setting, so that they can then process, get the information that they need, so that when they have that first prenatal appointment, things are not a surprise, and the conversations could be had a little easier. Next slide, please. So this is a quick snapshot of what the risk assessment looks like. We are in the process of getting it IRB approved at Stanford, and we'll be piloting it. Next slide, please. And this is a simplified version of the patient risk assessment. We're doing a little bit more detailed and then a simplified version. So one was 21 questions and this one's 7. So we're going to be piloting both, see if there's a difference. And if we can go with the easiest one, then we're going to go with the easiest one. We plan on piloting it with 200 patients in English and Spanish. Next slide. So the healthcare system, what can we do? What do we need to do? Maybe a little bit different when people come into our healthcare system. Next slide. And something to keep in mind when we're looking at initiatives is the fact that 23% of mental health conditions is the leading underlying cause of pregnancy-related deaths. 14% hemorrhage, 13% cardiac and coronary conditions. Next slide. In California, you can see here the related maternal mortality in 2020. There's a higher rate of pregnancy-related deaths for Black birthing people. Again, the disparities in the Black population. Higher rate of pregnancy-related deaths with Medi-Cal health coverage, so lower socioeconomic factor, and then higher rate of pregnancy-related deaths when living in the least healthy community conditions. Can I have the next slide? So what we are looking at after having looked at several surveys is looking at the obstetric comorbidity index to predict severe maternal morbidity. And this is a validated tool that is used in some healthcare settings, and it could potentially identify at-risk individuals whose condition warrants increased surveillance and targeted care to prevent adverse maternal outcomes. This is already being used in India, in Canada, Finland, been validated in Canada, in Finland, being used in the Cleveland Clinic. So this was created by Dr. Brian Bateman when he was at Harvard. Next slide. So we can't do this alone. And HRSA has recognized really the investment and the opportunity there is in California. And I wanted to highlight some of the key partners that we have here in California. One is in LA County with Mama's Promise. They received one of the HRSA's innovation grants, and what they're doing. We talked about the fact that 23% of the maternal mortality was due to mental health conditions. Mama's Promise is really looking to replicate a resource for providers to get the care to be able to support any healthcare provider in LA County for mental health conditions. You can call somebody and they can tell you what you need to do in terms of helping your patient. The other is the Charles Drew University. They have a safety net perinatal medical home that they're developing in their region in SPA 6, and California Maternal Quality Care Collaborative, focusing to reduce maternal mortality and morbidity. And they're doing this in collaboration with DHS, the work that's happening here in California, as well as public health and our office and all of our partners throughout California. So this represents over $30 million investment in California. The timing is right. What each one is doing separately in their own region really can be replicated, and we can expand throughout California. So excited to be able to partner with all of these three organizations. Next slide. Toxic stress can lead to many negative outcomes, and this is an innovative way to really think about opportunities to improve health. I don't know that this video is going to work, but we can.
Good morning, Diana. Yes, it should. And I got the video and the sound ready.
So for those, you can play it. So for those of you who
Very
are
good.
not aware of ACEs, this is what ACEs is all about, adverse childhood experiences. Okay, so it doesn't look like it's working. So adverse childhood experiences.
Childhood experiences,
Oh, it works.
ACEs, are stressful or traumatic experiences.
There we go. Sorry. There we go.
So we can't hear it, Christina. So let's just stop it, please.
Okay, thank you.
So basically what ACEs are adverse childhood experiences. And it's something that was done and research by Dr. Feletti down in Kaiser, San Diego. And what Dr. Feletti realized after caring for over 15,000 patients at Kaiser San Diego was that when patients, I think it's the next slide. Well, okay, let's, oh, here it is. Okay. Oh, let's
You
go on
want to
to
go
the next one.
Okay.
Okay, so he had a practice, he's a internal medicine, preventive medicine physician, bariatric clinic. And so he would have patients that came in to lose weight. This is an example of a 28-year-old, 400 plus pounds. Next slide. After a few weeks, they would lose the weight, 29 you can see her before and after, but then she would gain the weight again. And finally, he asked the question, what is happening that you go back to the weight that you were before? And she said, can I have the next slide? The next click. She said, well, when I was a child, I was sexually abused and molested by my father. This is her at 8 years old. She said, I was very pretty, very cute, and my father would tell me that. And so what ended up happening is that she would tell her sister, who was younger, you need to overeat, you need to, gain weight, because she didn't want the same thing to happen to her sister. So what ended up happening is that when she had lost the weight, she realized that men were coming onto her, were trying to, again, sexually abuse her. And she said, no, the weight is my protective shield. And so critically important to realize that adverse childhood experiences, and the previous slide showed it, increase the cortisol level, changes the hormones that really can impact not only learning, but impact your health throughout your life. Can I have the next slide? So adverse childhood experiences, 1 in 6 people experience 4 or more types of ACEs. There are basically 3 categories of ACEs: abuse, neglect, and disruption in the household, of which mental health in one of the parents is one of those. When you do the ACEs questionnaire, there are 10 questions. And if you have 4 or more positive that are present, that increases your risk for negative outcomes. 5 of 10, at least 5 of the top leading causes of death are associated with ACEs. So we talk about preventive health upstream approach. This is one of those upstream approaches. Can we have the next slide? So these are the things that can potentially decrease if we address ACEs in childhood, less than 18 years old. Depressive disorders decreased by 44%. Remember, we saw 23% of maternal mortality was due to the mental health disorders. Wow, if we can prevent it, wouldn't that be wonderful? You can see the rest of the other medical conditions. Chronic obstructive pulmonary disease decreased by 27%. Obesity decreased by 2%. Coronary heart disease. Remember what coronary heart disease was the 3rd common cause of death? Decreased by 13%. Next slide. Next slide. Behavioral risk factors. Smoking decreased by 33%, heavy drinking by 24%. So you may be asking, how can this be happening? The way that I analyze it is people are protecting themselves. People are self-medicating, whether it is with food, with drugs, with alcohol, with negative behaviors. They're self-medicating in order to try and forget, try and avoid the negative impacts of those adverse childhood experiences. Next slide. So like everything else, there are health disparities, and not everyone is impacted equally. There's more impact in those with who are LGBTQ+, low income, women, Black, Latinx, Indigenous, people of color. It's like, unfortunately, the same people who are impacted over and over again. And discrimination experienced by these same groups includes racism, and is also a risk factor for toxic stress. Next slide. So what are the things that we can do? Because, this is how adverse childhood experiences looks like in terms of race and ethnicity. And you can see that those with 4 or more ACEs, remember we said that was worse when you have 4 or more. American Indian, Alaska Native, 31%, they have the highest rate of 4 or more ACEs, followed by African American and Hispanic. Remember, it is these negative ACEs that lead to all of those negative health outcomes. So maybe we should be focusing on ACEs to try and, again, prevent those medical conditions that will set us up for not only negative lifelong health, but if a person becomes pregnant, complications in pregnancy and beyond. Next slide. In terms of gynecologic conditions, you can see here the association with ACEs and gynecologic conditions. So this, I want to emphasize this, ACEs induce chronic stress, and the resultant hormonal and immune imbalances are related to the observed associations. So this is why we're seeing that, because of those hormonal and immune imbalances. Next slide. And these are some more outcomes in reproductive health. So unintended pregnancy, teen pregnancy, you can see here on and on. So when you have that chronic pelvic pain patient, maybe you should be doing an ACEs screening to really understand that perhaps what they're experiencing is something more than just pain. There's an underlying trauma that has that person's been experiencing. Next slide. And in terms of perinatal outcomes, again, increase in miscarriages, preterm birth, and low birth weight with higher number of ACEs. Remember, we said there's up to 10 on the questionnaire, and you can see here the higher the number of ACEs, the higher the frequency that you see of pregnancy loss, preterm birth, and low birth rate. Next slide. And this is a sample of what Kaiser Permanente in Northern California is using for their ACEs screening. And this is from a publication by Dr. Tracy Flanagan back in 2018. So remember that the initial ACEs studies were done in Kaiser, Southern California, and that was in 1995. So there are over 15,000 patients that have been answering this ACEs questionnaire, and it's just a matter of us realizing the opportunities that we have in acting on what we find from the questionnaires. Next slide. In terms of ACEs, I know when I first heard of it, I thought, wow, what can I do about it? Are there anything that can be done? And absolutely there are, and those are called positive childhood experiences. There are things that you can do for yourself as an individual, and you'll see a slide coming up that helps you with stress, with all sorts of mindfulness recommendations, but there are more importantly things that can be done in the community. So these are the key things. You just need one positive experience, one positive person in your life to help you overcome some of the negative ACEs. And so you can see here that the group that has the highest number of positive experiences, remember the positive experiences by the community can mitigate the ACEs. But look at the American Indian and Alaska Native, you can see they have the highest number of positive childhood experiences. But they had the highest number of ACEs too. So there are a lot of community and tribal rites of passage that happen in the Native population that helps mitigate the negative number of ACEs, the higher number of ACEs. The same thing with the African American population. And I do want to highlight that the Hispanic have the lowest number of positive childhood experiences. Remembering that 40% of Californians are Hispanic. So this really does impact the entire outcome, entire state, because remember, the higher the number of ACEs, the higher the probability that there's going to be chronic medical conditions and negative health trajectories. Next slide, please. So this is a quick snapshot of positive childhood experiences and things that can be done in order to mitigate the ACEs. Talking to family members about your feelings, having the support when you feel like there's difficult times, community traditions, belonging in high school, friends, one parent that genuinely cares for you and feeling safe and protected in an adult home. And I can tell you personally, having grown up in South Central LA and having really probably experienced a NACEs level of about 5+, that it was one of my positive childhood experiences was my aunt who lived across the way from me. When I would come home, latchkey kid, and she would sit me down, say, I saw you just got home, come on over and sit down with me and ask me, how was your day? And it would have that milk and nice warm chocolate chip cookie she had just made. It is those small experiences that make a difference in a person's life. Next slide. So you can use a QR code to, let's not even try with the video. You can use it.
I'd love to. If you're, everyone's good. You know, we have almost 300 folks on, Diana.
Okay, so this is something that I love, and I hope it works.
Me too. And we're gonna make it work. Gosh darn it. So let me get this going here. Oh, too funny. Oops.
Oh, we lost
yeah,
the
it's all right.
completely. Okay.
I tell you, it's one of those mornings. Let me get it going here again.
No, it's not going to work. Oh, here we go. Well, you got to snip it. That's okay, Christina. You got to snip it. And basically, sometimes we just have to remember that it's the simple things that make us laugh that can change our mood in the instant. And so for honestly, Christina, right now for me, thank you so much. That helped mitigate all of these challenges that we're having this morning. But it's
you are very
little
kind.
thing. It's in the little things that we need to keep in mind that sometimes we just have to step back and just laugh. And I would encourage you, if you can, to go to that video, but it is one of my favorite because you can't help but laughing the more and more you hear the baby laugh. And as I mentioned, there's a QR code there to access some of the personal things that you can do for yourself. Can we have the next?
You bet. Woo. Again there. Oh, my PowerPoint is having issues. Hold on a sec. I tell you, we're throwing one of everything in this morning.
So the next slide, I'll just start talking about it, has to do with mental health. Again, going back to the fact that 23% of maternal mortality was associated with mental health issues. We can't forget that 1 in 5 people in the US have mental health, are impacted by mental health issues, and 1 in 25 people are impacted every year by severe mental health issues. More importantly, we know that during pregnancy, that is the time when mental health issues oftentimes surface because of the hormonal changes, the stress, multiple factors. So I'm not sure what's happening, but okay. So we just need to be sure that mental health is addressed. We know that adverse maternal mental health conditions are increased with more ACEs. When people who are pregnant are depressed, they have a higher ACE score. And there is a higher risk for preterm delivery, higher risk for low birth weight. And unfortunately, if you happen to be Black, are pregnant, and you have depression, you have a 2.3 increased risk for preterm birth delivery and 2.47 increased risk for low birth weight delivery. So mental health is so critically important. We have to remember that mental health. Oh, okay. So here's a slide. One more click. Okay, thank you.
Okay.
One more click. Okay, we talked about that one. One more click. One more click. I want to highlight the fact that there are some amazing resources that have just been launched by the state, California, Youth Behavioral Health Initiative. This is a $4.7 billion investment from Governor Newsom, and it is really reimagining what behavioral health should look like, how help should be acquired. And these apps, the one on the left, the Bright Life Kids, is for parents for 0 to 5. And if you have older kids, you can still use it. I actually signed up for this, and you put in there how old your child is and how you can help them. The apps are for people 0 to 25 years old. So, go ahead. If you're a young adult, use it. The Soluna is the one that is providing the support for youth, young adults, and families. These are amazing resources that are free. Soluna, you can use chat AI technology to be able to access support immediately on the spot. And you get also connected with somebody in your community if you need that extra mental health resource. So these are amazing free resources. Check them out. I was at a meeting with nurses a few weeks ago. The nurse was from Fresno, and she said, we don't have enough mental health providers. She logged in, she created an account, and she was so impressed. She said, this is an amazing resource. She was going to share it with all of her community. So this is one little bridge to be able to use technology, meet people where they are, and provide the support that is needed. Next slide. So with that, oh my goodness, we made it. We made it through this. So as challenging as it was, thank you so much for the opportunity to share the innovative direction that we are going here at the Office of the California Surgeon General. This is work that is not being done alone. This is truly a cross-collaborative initiative that we are all coming together. Thank you to all our partners that are here with us. And if there's anyone that wants to participate in some of the initiatives that we are working on, please send me an email. There's our QR code. Would love to connect with you and have you be part of our success here in California.
Diana, thank you so very much. We'd love to now start a bit of Q&A. Are you good with that?
Sure. Not sure how that's going to go, but
yeah, no problem. Can you speak to the importance of qualitative research and explain? Because a lot of people don't know the difference.
So, we need qualitative and quantitative research, and especially when we're working with innovative information. This is one of the reasons why we are doing the nickname for it is called PRIMA, the Patient Initiated Risk Assessment, because we want to make sure that we have insight on all levels of research. For some folks, qualitative research is what drives them, but for others, the quantitative research is the data that is needed to be able to apply to grants. But we need both in order to move the needle forward and to understand the direction we need to go.
How much does correcting for health-related social needs ameliorate the impact of ACEs on those of color?
So far,
yeah.
looking at the social determinants of health is absolutely one of those pieces, and that's one of the reasons why there are higher ACE scores in those who are low socioeconomic environments, right? And so all of that goes hand in hand. We have to remember 80% of health happens outside the healthcare setting, and it is all of those environmental issues that really come into play. You have to realize if you are a child and your family is unhoused or you're in a multiple living environment, your parents have to be working, there's stress in the parents, it just all perpetuates. So it really is a combination of everything that comes into play when we're looking at those adverse childhood experiences. And that's why the CDC is looking at really a multi-tiered approach in addressing ACEs, from communities to states to now really in helping individuals. There was a recent AASHTO publication that is encouraging states to address ACEs because the realization is there, wow, this is an upstream opportunity to help put people on a more positive trajectory. And we just need to use the resources that are already there to leverage and improve the outcomes.
What about, in your experience, even as an obstetrician and gynecologist, it's difficult to get folks to open up, especially in a short period of time, to talk about their lives and, any suggestions and any ways that you thought in your career that have helped folks to be able to open up?
I think the most important thing that I have found over the years is to stop, look at the patient in the eye, and listen.
Oh.
I teach at USC Medical School at Keck, and I encourage the medical students. The most important thing you can do for your patient is just to listen to them, and your patient will tell you exactly what's wrong with them. Instead of you trying to come up with the differential and explanation, just listen to your patient. If you can, hold their hand, and that's going to be the healing, the human touch that makes a difference. That's the start.
Folks in the Q&A and the chat are discussing the importance of having a diverse workforce, and you've mentioned that. Physicians, nurses, midwives, the entire spectrum. Can you speak to the impact on outcomes, again, when on all folks with having a diverse workforce?
I think everyone, the data is there, and we know that there is increased rapport, increased adherence to recommendations when the provider looks like you, when the provider can understand your culture, and if they can speak your language, even better. But we know that that is a huge need. In California, we have 3% physicians that are Hispanic. Nationally, it's 6% Hispanic, 8% Black. And so we look at our population, it is not reflective. And so could that be a solution to help improve adherence, trust, outcomes? Absolutely. But it's not, as you all know, it's not so easy to get into nursing school. It's not so easy to get into PA school, become a midwife. And so we need to encourage each other, support each other. I am a firm believer of mentorship and pulling at least one person up to where you are and pushing them forward ahead of you. I think together we can all do that.
Thank you. Savannah signing off. Can you talk, there's a lot of talk, a lot of coverage about closures, hospitals closures, service closures. Can you update us on that?
Unfortunately, I cannot. That is a multifactorial issue, and there are other people in our sister agencies that are focusing on that. So I'm sorry, I am not able to talk to that.
Yeah. I know with the work that's going on up in the state about the importance, you mentioned it in the deck about risk. You and I have discussed before about preconception care, planning for pregnancy, and identifying those risks early on. You have a passion for pre-pregnancy care. Can you speak to that?
I think I have a passion for wellness, for health in general. And if it happens to be in that pre-pregnancy time, then that's what we're going to call it. If we're going to call it postpartum, then that's what we're going to call it. But really, it is in wellness, and we need to just strive for that. Again, as it's changing the narrative. It's just talking about health. Let's focus on health and opportunities to improve health, taking into consideration those social determinants of health. And I've said this many times in the past, we need to meet people where they are. And yes, we can encourage them to walk, to do more exercise. But let's realize that oftentimes you live in an environment when it is not safe for you to be walking outside, where there are no sidewalks, where there are cracks, where there maybe is no road. And so what can you do? And that's where creative, innovative solutions come into play. And that's what we have to do, whether it is dancing in your living room with your with your grandchildren, with your children, whether it is doing some type of mental health ministry in your places of worship. All of these are innovative ways where, again, community can help support health. And I think that if we start to think of health as not something that the doctor does or the nurse practitioner or the midwife does, it's something that we all do as a community. We start to change that narrative, change that mindset. We are going to slowly start to move the needle.
And our last question, which kind of speaks to that, and the importance of diet and access to healthy food. And maybe if you could, just speak to that. And again, the entire spectrum of a person's life, right? Not solely for pregnancy.
I'm not sure what the question is there, Christina.
Can you just speak to the importance of diet and food in a person's life, as well as you just discussed spiritual, exercise, other aspects?
Yeah, so diet we know is a foundational, right? It's a building block. It starts when breastfeeding from as a baby. We know the positive impact on health. And so absolutely being able to have access to nutritious food and vegetables is so critically important. I'm very proud to say that, the governor, the first partner, have promoted and have implemented, the free breakfast and lunch in the public schools. How wonderful is that? And there are some farm to school programs that the first partner has promoted and has set so that children have access to fresh fruit and vegetables in their public education schools so that they can have the healthiest food they can access. The state is partners with the federal WIC programs, again with the SNAP programs, the ability to use your benefits at farmers market. We know the importance, and I'm so honored to partner with a state and be part of the partnership with the governor and the first partner that recognizes the importance of access to fruit and vegetables and creating programs that increase the access to that. There are many community farm programs as well. So we know that not everyone has access to it in the supermarket, but there are communities that are starting their own little community farms, and they can grow it themselves. It's a matter of teaching and then helping support and encourage folks. You have to learn the importance of a good nutrition, a good diet, so that you can then reinforce the good behavior. And we are doing a lot here in California to do that.
Diana, I don't know that there's been a more gracious person in this situation. And we want to thank you. Thank you for taking the Q&A. Thank you for hanging in there with us this morning. It's been an honor to have you. And we thank you for your work again, not only for women, but for families across California. So thank you, Dr. Ramos, very much. And we hope you have a looking up day.